Um, all right. Hey, y'all. I'm Dr. Boatwright. I'm one of the emergency medicine residents at Freeman Hospital. I'm a first year resident. A little bit about myself. I went to med school at the University of Kansas Medical Center. I'm from the Kansas City area. Before I went to med school, I was a paramedic for about a decade. So, some experience on the ambulance. And this presentation is going to be pediatric cardiac arrest, recognition, management, and outcomes. Just FYI, this is going to be case-based and hoping to get some interaction with this. Also, this is my first time doing this presentation, so I might have to work out some of the kinks. Otherwise, just kind of bear with me and let's get started. Is that audio good for everyone? Okay. All right, so here's the objectives: understand common causes and mechanisms, recognize cardiac arrest promptly, perform high quality CPR, and apply the algorithms, and then don't forget about like post ROSC care. I know PEDS cases can be scary for all of us. Probably the scariest calls that we get on the ambulance and in the emergency department as well, or when the little ones come in and they're sick and need CPR. So we're going to start with a case. This is a 2-year-old female in PEA. Here's the questions that I want you guys to be thinking about for this case. So I'll let you guys look at these for a second. So most important next steps, and then the likely underlying cause of cardiac arrest. Here's the case. We'll take about 5 minutes. We'll think about those questions, and then we'll come back. All right. If you guys are ready, we can go ahead and resume. I was planning on having someone read the case. I don't know if that'll be an option.
Show good audio on that. So we got a 2-year-old female brought in to the ER after becoming increasingly lethargic and unresponsive at home. Her mother reports that the child's had a fever, vomiting, poor oral intake for the last couple of days. She's unresponsive, pale, without a palpable pulse. The monitor shows PEA. CPR's started immediately. After 2 minutes of high quality CPR, she receives epi 0.01. Compressions are continued after 2 more cycles. CPR ROSC has been achieved. Initial post ROSC vital signs: pulse of 168, pressure of 68/38, respirations at 28, SpO2 of 93% at 100%, temp 38 degrees Celsius. I'm going to need that in Fahrenheit, sir. And cap refill of greater than 4 seconds. Physical exam: lethargic, cool extremities, weak pulses, mottled skin, dry mucous membranes, no trauma or signs of airway obstruction. Lungs are clear, abdomen soft, and glucose 54.
Okay, so we'll move on to questions here. Anyone want to volunteer to offer up their thoughts on what are the most important next steps in the management of this child after ROSC?
Started on 20 milligrams or 20 cc's per kilo of fluids. Their pressure's up and also running IV glucose.
So yeah, very good. So underlying cause of this case, most likely hypovolemic distributed shock due to sepsis, leading to the PEA arrest. The contributing factors of dehydration, poor perfusion, and hypoglycemia. So post-ROSC management priorities are going to be, always, airway and breathing, ABCs, we focus on those. So we want to ensure airway patency, consider early intubation for airway protection and controlled ventilation. We'll maintain oxygenation with a good SpO2 sat and normal capnic. And then for circulation, like the gentleman here offered up, aggressive fluid resuscitation, 20 mils per kg, isotonic crystalloid boluses. Be sure to monitor for fluid overload, as always when we give fluid. And then epinephrine infusion if persistent hypotension and poor perfusion. Want to correct the hypoglycemia with dextrose. And then sepsis management is going to be obtaining IV access, blood cultures, broad-spec antibiotics within the first hour, and then maintain normothermia, avoid hypothermia. For monitoring, we'll do continuous cardiac and pulse ox monitoring. I do realize that some of this may be outside of your scope, but we'll kind of just expose you a little bit to what happens in the emergency department. So for labs, we're going to get ABGs, electrolytes, lactate, renal function, CBC, and then we'll consider central venous access and ART lines if there's ongoing instability for this patient. Teaching pearls for this case. In children, cardiac arrest is most often secondary to hypoxia or shock, not a primary cardiac event. PEA or asystole is most common arrest rhythms. And then just like adults, epinephrine every 3 to 5 minutes, high quality CPR is the main thing we want to focus on. Always identify and correct the reversible causes, the H and T's that they hammer into us. In this case, hypovolemia, hypoxia, hypoglycemia, sepsis. So here's the epidemiology of pediatric cardiac arrest: 16,000 out of hospital arrests per year in the United States. Survival rate being 10 to 12%, with the in-hospital survival rate being 35%. And then, as we mentioned earlier, the respiratory etiology predominates. So common causes by age. Does anyone have any ideas for what the most common causes would be for some of the different age groups, including infants, children, adolescents? Anybody for infants?
Congenital defects or kids, sons, whatever they call it now.
Yeah, very good. How about for children?
Foreign body airway obstruction. Oxygen, airway compromise.
Yep. How about for adolescents?
Probably drug use. Trauma.
Yeah, very good. I think you guys nailed them all. So for infants, SIDS, respiratory infections, congenital heart defects. For children, traumas, drowning, and sepsis. And then for adolescents, arrhythmias due to toxins and traumas. Pathophysiology, you guys all know this, just a refresher. So hypoxia leads to acidosis, which leads to myocardial dysfunction, then decreased ATP production and cell death. The cycle continues, and hypoperfusion and tissue injury persists, eventually becomes unreversible. All right, early warning signs. Does anybody know some early warning signs for impending pediatric cardiac arrest? Yeah, so in particular with kids, the etiology is usually respiratory driven. So respiratory distress, and then as the gentleman mentioned, altered mental status or lethargy. Rapid recognition of these signs can prevent a cardiac arrest from happening. All right, initial assessment. So what's the initial assessment going to be for these patients? Same as every patient, right? ABCs, check responsiveness. Of course, the pulse check, we want to keep into less than 10 seconds. Absolutely. Yep. Okay, so what's our CPR technique?
Which guideline? 25 or 20?
Let's throw some out there. So how about for compression depth?
Third the depth of the chest wall.
Yeah, that's right. Or 5 centimeters for children, 4 centimeters for infant. The rate, still going to be 100 to 120. And then the ratio will be 30 to 2 for a single rescuer and 15 to 2 for 2 rescuers. As was mentioned, those guidelines can vary depending on which particular set of guidelines you are following. So for airway and breathing, with the BVM with supplemental oxygen, want to avoid hyperventilation and hypoventilation. Then one of the best ways to gauge for adequate ventilation is to monitor for chest rise. All right, anybody can list some quality metrics that we can use to make sure we're giving good CPR? All right, so we had end-tidal CO2.
Oh, yeah.
Staying Alive song. Okay. So what I think of for this is like minimizing interruptions and compressions, because compressions, are the most important thing for keeping the cerebral perfusion pressure to where it needs to be. We want to allow for full chest recoil to make sure that we're getting good circulation, and then making sure that we're having fresh compressors switching out every 2 minutes. All right, so for rhythm recognition, I think of it as in two main categories. Does anybody want to offer up the two main categories for rhythm recognition?
Fast and slow.
So for a cardiac arrest,
Oh, shockable, not shockable.
shockable and non-shockable, very good. So some of the shockable rhythms, VFib, pulseless VTAC, and then the non-shockables, asystole and pulseless electrical activity. Defibrillation, does anybody know the joule dosage for the first shock? Yeah, how about for the second? Okay, what's the max dose? Yeah, very good. So 2 joules per kilogram on the first shock. The second can be 4 joules, and then the max or adult dose is 10 joules per kilogram. So we want to make sure that we're quick to get back on the chest immediately after shocking. All right, epinephrine use. Who knows the dosage of epinephrine? Yeah, or 0.1 mils per kg of the 1 to 10,000. Yeah. Yeah, exactly. So that's going to be every 3 to 5 minutes, just as in adults. Want to make sure that we're giving it as quickly as possible for the non-shockable rhythms. And then amiodarone and lidocaine. Anybody know the dosage? Amiodarone is 5 milligrams per kilogram. IVIO bolus for refractory VFib, pulseless VTAC. How about for lidocaine? Do you guys use lidocaine? So I don't see lidocaine used as much anymore, but we still do have the guidelines being 1 milligram per kilogram as the initial loading dose. Okay. So for airway management, what sort of options do you guys have for airway management in the pre-hospital setting?
Everything from basic oral airway adjuncts.
So oral adjuncts, OPA, NPA. You guys have eye gels for your supraglottics, okay? And then, of course, the advanced airway would be the ET tube. That's going to be the definitive airway. And then how to confirm placement. Like we talked about this earlier with end-tidal CO2 waveform capnography is the best metric for confirming adequate ventilation. All right, so monitoring and team roles is crucial during CPR. Let's see, can anybody name some important team roles? Yeah, team leader is one of the roles, and that'll be the person who divvies up the other roles, which would be so we got recorder, CPR, airway. Yeah, I think that's all of them. So the leader is going to be the most important role, telling everybody else sort of what to do, coordinating the show, and then the second most important role would be the compressor. Make sure that we're doing effective compressions. Then the airway role, so this will be the person that manages the airway, and then the recorder. This person can be important to chiming in for timelines for when drugs and shocks can be given. And then, of course, we want to use a closed loop communication for effectively communicating. All right, everybody's favorite topic, reversible causes. So the H's and T's Sure we all know those. Anybody want to volunteer up the H's and T's? Hypoxia, hypovolemia, so hydrogen ion or acidosis, hypo and hyperkalemia, hypothermia. How about the T's? Toxins, tension pneumo, cardiac, tamponade, and then pulmonary thrombosis. Yeah, very good. All right, so here's the current AHA, pediatric cardiac arrest algorithm. I'll just kind of go over this quickly. If we have time, we can maybe come back to it at the end. But starting CPR with bag ventilations, giving oxygen, attached to the monitor. Is the rhythm shockable or non-shockable? For shockable, we'll go down the algorithm. Yes, give a shock, and then CPR for 2 minutes. Get IVIO access, and then reassess the rhythm. If it's shockable, continue CPR. After giving the shock, consider advanced airway. And then after that, we can consider amiodarone or lidocaine. For PEA, and give epinephrine as soon as possible, CPR for 2 minutes, IVIO access, epinephrine every 3 to 5. Consider advanced airway at that time. Reassess rhythm, CPR for 2 minutes, and then think about the reversible causes. So for CPR cycle integration, how often are we reassessing the rhythm? Yeah, so we'll reassess the rhythm every 2 minutes, and then what is the maximum amount of time that we want to spend checking for a pulse? Yeah, 10 seconds. So if we can keep it to like around 5 seconds is better. All right, and then termination of resuscitation. I think this is going to be mostly just based off your guys' local protocols. I think a pretty good standard amount of time is about 20 to 30 minutes. I don't know what your guys' protocol is here for pediatric arrests. Do you guys terminate pediatric arrests in the field? Never? Okay. So you're transporting all pediatric arrests. I like that. All right, so here's another case. So this one is a 6-year-old trauma. You guys are dispatched to a motor vehicle versus pedestrian involving 6-year-old male. Child was reportedly struck by a pickup truck traveling at moderate speed. Bystanders are performing CPR when you arrive. Here's the scene findings. And I'll go back to these. I want to show you guys the questions. So these are the questions I want you to focus on as the first EMS crew. What are the critical pre-hospital priorities and intervention for traumatic cardiac arrest? And then again, here's the scene findings. So we'll take a couple minutes and then we'll talk about the questions.
breathing on his own, or is that would it be the under initial assessment at the top it says that he's absent, and then it says absent breath sounds on the left.
Let's go back up.
CPR been started? That's where we're getting the absent breath sound. Or is he breathing?
So he is not breathing as bystanders are performing CPR. All right, so I'll go ahead and read these. Scene findings: child lying supine on the road. I guess CPR has been halted by the time of our arrival. There's a large scalp laceration, abrasions over the chest and abdomen, deformed right femur. Patient is unresponsive, apneic, pulseless. No evidence of penetrating trauma. On our initial assessment, airway is obstructed by vomitus and blood. No spontaneous respirations. So absent breath sounds on the left whenever we bag. No palpable pulses. Cardiac monitor shows PEA. GCS is 3. This patient's unresponsive, cold, pale. No major external hemorrhage. The time of collapse per witness was less than 2 minutes before EMS arrival. All right, so does anybody want to offer up their thoughts as first in EMS crew? What are the critical pre-hospital priorities and interventions?
In the airway, you start bagging, you start CPR, it's like hospital. He went into cardiac arrest because he vomited and choked on his own vomit.
Yeah, I agree. I think airway and breathing is our most important thing right now. As the gentleman said, clear the airway with suction and suction in the blood and vomit. Provide bag mask ventilations with 100% oxygen. Intubate if possible, taking C-spine precautions, and then as one of the people here suggested, at least the left side definitely needs needle decompression immediately, as breath sounds are absent on that side. And then for circulation, control external bleeding. This is going to be with pressure or tourniquet. Of course, in this case, there's no major external bleeding. We want to establish IO or IV access, give warm fluids or blood if available, and then continue high quality CPR while assessing for and correcting reversible causes. And then the reversible causes of trauma. Anybody want to offer up the H's and T's of trauma? We already talked about one, the tension pneumo. Tamponade, yeah. Of course, blood loss from hypovolemia, hypoxia is always a consideration. But this is kind of the typical order that we want to address those things in. And then it's time to transport. So if Ross, we're going to transport to Pediatric Trauma Center if available. If not, transport to your closest appropriate facility. And then if no Ross, you can continue on scene, although I find it kind of difficult to tell family or parents that you're not going to transport pediatric cardiac arrest. So I think typically we're going to transport these patients.
I do have a question.
Yes, sir.
On the intubation, you have no breath out. You want to pull back on the tube first and try to breathe, or just go ahead because of the paramedics?
Yeah, you probably would be doing those things like simultaneously, ideally. But I mean, if you're the only paramedic there, you typically want to probably just provide bag mask ventilations until you get the needle in for decompression. You don't want to make that tension pneumo worse than it already is, right?
So don't worry about pulling back on the tube for right.
Yeah, because I think for this case, the absent breath sounds were just with BVM. Yeah. All right, so for the next set of slides, we'll talk about special circumstances. All right, so for hypothermia, um, rewarm gradually. It's 0.5 Celsius per hour. And then what methods do you guys use for rewarming?
Typically don't.
Just warm blankets, or dry the patient off if they're wet. Yeah.
Well,
Warm fluids.
I totally misunderstood the question.
Yeah.
I'm gonna hush now, I'm sorry.
All right, so moving on. Okay, what are the special considerations that we want to think about with drowning pediatric patients? Anybody have any ideas?
Mind repeating the question?
Yeah, so what are the special considerations that we'd want to consider for drowning pediatric patients?
Water, temperature of the water.
Yeah, so warm if they're hypothermic.
Salt water versus
Sure.
length of time.
Yeah, so as always, like, prioritizing ventilation and oxygenation in the pediatric arrest. We talked about warming if they're hypothermic. And then a couple other things to consider are, is this a traumatic injury? Like, how did this patient end up in the water? Did they maybe get a cervical spinal fracture from diving in? And then want to consider intoxication as well. All right, how about for trauma? We've already kind of talked about some of them. So controlling hemorrhage, obviously, anything open gets direct pressure, and then got your tourniquets if necessary. Treating tension pneumothorax as we did in one of our previous cases. All right, how about for sepsis? Yeah, for sepsis, fluid resuscitation, antibiotics, and then in the emergency department, we'll consider looking for source control. How about for electrolyte imbalances? Yeah, this is probably going to be mostly done in the emergency department. For electrolyte imbalances, we're going to correct potassium, sodium, and calcium disturbances. For toxins, exactly. So identify the toxin and antidotes. And then do you guys give any in the field? Do you guys have any particular antidotes? So I can think of one or two actually, that I used to use on the ambulance. This next one is mostly going to be in the emergency department. This is going to be for like Tylenol overdoses and acetylcysteine. A couple on the ambulance, though, are going to be bicarb, so sodium bicarb for your tricyclic antidepressant overdoses, and then glucagon is useful in beta blocker overdoses.
Glucagon is incredibly expensive.
Oh, you guys don't have it on the ambulance?
No. Yeah, crazy expensive.
Oh, really?
Yeah, very effective for beta blockers.
Yeah, sure. Yeah, that's too bad. All right, any ideas for congenital heart defects? So this is going to be for hospital use only. I don't think that you guys carry any prostaglandins for ductal patency. And then cardiac tamponade. You guys know the treatment for that? Yep. Pericardiocentesis. Of course, I don't think you guys are doing that in the pre-hospital setting. Yeah. I think I've heard of, I don't know, maybe some old head saying that this was done back in like the 80s or something. Yeah, gotcha. All right, how about for PE? This is going to be in the hospital setting again, but yeah. So in the hospital, it's going to be fibrinolytics in select cases, and then thrombectomy for other select cases. And then neonatal considerations. So there are distinct algorithms in NRP versus the PALS. I unfortunately do not have those algorithms with me today, so we'll have to come back to that another time. And then these next set of slides are going to focus on post-ROSC care, which I think a lot of times sort of gets brushed to the side. People forget about it. We get all excited about taking care of the code, and then once we get pulses back, it's kind of like, what now, you know? So this is something that we need to be considering and be training on a somewhat regular basis. And it's going to be hemodynamic stabilization, optimization of perfusion, and oxygen delivery are going to be key. And then for temperature control, we kind of already discussed some of these for the hypothermic patient. But then for other cardiac arrests, you can consider like temperature targeted hypothermia. So I think that's going to be sort of protocol driven again in this case. I don't know if you guys have a protocol for cold fluids.
You were answering or asking a while ago that I answered.
Gotcha.
Difficult to achieve in the hospital.
Yeah.
Cold. We don't really have a great way to measure it.
Right, that's true. I feel like this is, I don't know, this is kind of something that, at least when I was working on the ambulance, like maybe 5 to 10 years ago, that there was a big push for targeted temperature control, and then it just like slowly phased out. So, all right. How about for glucose and electrolyte management? It's just going to be, what was that? What was that? Yeah, that's kind of the primary one, I think, for you guys, is avoiding hypo and hyperglycemia, and then replacing electrolytes as needed, which will be more done in the hospital. I don't think do you guys carry insulin or have a protocol for shifting? Okay. And then neurologic management or monitoring. So I think this is, at least from my career, from what I remember, I don't really remember being taught to do this or there being much of an effort around education with this. But obviously, you guys are not going to do EEGs in the pre-hospital setting, but you can do frequent neuro checks and progress or monitor for progression in your patients on the way to the hospital, especially if you have a long transport time. And then something else that is sort of not taught or talked about a lot, but can be very challenging, I think, especially for like new paramedics, is handling or talking to family on the scene. This can be something that's very difficult. So not only that, talking to family can be difficult, but then anytime you're working a pediatric code, these are going to be like the worst cases that we have. So kind of need to think about the toll that it takes on each of us. So just kind of being there for your teammates, I think, is important. If you guys do like organized debriefings, I think there's some evidence that suggests that can be beneficial to staff moving forward after a traumatic event such as a pediatric code. All right, so here's our next case. So here's the questions I want you guys to think about. Most important next steps in post-cardiac arrest management of infant, and then what do you think the underlying causes that should be prioritized for evaluation. So let's take a few minutes and read through this, and then we'll reconvene here shortly. All right, so that might not have been enough time for everyone to get through it, but in the interest of time, we'll go ahead and move forward with this infant respiratory arrest case. So, case scenario: 6-month-old infant brought to the emergency department by parents after being found unresponsive in crib. Baby had had a mild cough, runny nose for 2 days, but was feeding normally. And then early this morning, mom found baby not breathing and limp, called EMS immediately and began CPR as instructed by dispatch. EMS arrived within 4 minutes, continued high quality CPR. After another 4 minutes, ROSC was achieved. On arrival to the ED, infant is breathing spontaneously but remains lethargic. The vital signs are heart rate 142, respirators 32, BP 78/45, SpO2 is 96 on 2 liters, and temp is 36.2 Celsius. On the physical exam, the child is lethargic but responds to pain. Breath sounds are coarse bilaterally with mild subcostal retractions. There's no cardiac murmur, and pulses are palpable. Cap refill is 2 seconds. So what do we think are the most important next steps? I do realize that this is maybe out of your guys' wheelhouse, but in post-cardiac arrest management of this infant. Yeah, so I think we kind of have touched on this several times, but the primary cause, or the most typical cause of cardiac arrest in children, is going to be related to respiratory. So, and then, this goes with just all of our patients. Focus on ABCs, ensuring airway patency and adequate oxygenation and ventilation. Yeah, I don't think that it was relevant to this case. I would just assume that it was normal. Consider early advanced airway, as this kid is lethargic and pretty sick and not breathing effectively. We want to avoid hyperventilation. And then for hemodynamic support, we're going to monitor for hypotension, initiate IV fluids and vasoactive support if necessary, maintain a normothermia and normoglycemia, neuroprotection, so monitor for seizures, manage with appropriate epileptics if indicated, and avoid hypothermia. And then we'll identify and treat reversible H's and T's. So likely causes in infants, respiratory failure are going to be bronchiolitis, aspiration and airway obstruction leading to apnea. Then others, at least one of the folks here in the room had mentioned hypoglycemia, along with sepsis, congenital heart disease in these very young patients, and then metabolic disorders as well. And they kind of touched on this earlier, but don't forget about the family support. And then the further workup in the emergency department is going to be some labs, including glucose, electrolytes, ABGs, and lactate. And then imaging will be chest x-ray, and then on down the line, you get your echo.
Is this an actual case?
No, this is just a made-up case. Okay, here's another case. This is a drowning victim, and we'll kind of just work through this one together as we have a couple more. But so this is a 4-year-old girl pulled from backyard pool after being found face down, unresponsive. Estimated submersion time is 5 minutes. Father immediately started CPR while another family member called 911. When EMS arrives, child is still pulseless and apneic. High quality CPR is continued. AED shows asystole. After 8 minutes of CPR, ROSC is achieved. On arrival to the ED, she remains unresponsive and is being ventilated with a bag valve mask. Vital signs are heart rate 72, assisted respirations are 20, BP's 85/50, SpO2 is 94 on 100% O2. Temp is 31 degrees Celsius, which is 87 degrees Fahrenheit. Blood glucose is 76. On the physical exam, pupils are sluggish but reactive. Lungs are coarse, breath sounds bilaterally, skin's cold and pale, and no external trauma. So what do we think the key management priorities for this child? Yeah. How should we do the hypothermia management in this case? Yeah. So airway and breathing takes priority always. Continue the ventilatory support. Avoid hyperventilation. Suction as needed. There's always a risk of aspiration and pulmonary edema. Obtain ABGs and chest X-ray in the emergency department. For circulation, monitor the EKGs and hemodynamic changes. Treat hypotension with isotonic fluids. Can consider inotropes if persistent. I don't think you guys are doing that in the pre-hospital setting. But for hypothermia management, this is something that you can do. So this is moderate hypothermia, 30 to 32 degrees. And for rewarming, I think some of the people here in the classroom had mentioned active external rewarming with warm blankets, the forced air warmer, the bear hugger, warm IV fluids. We don't want to overly rapid rewarm the patient to prevent hypotension and arrhythmias. And then continue resuscitative efforts until core temp reaches greater than 32. For neurological and post-arrest care, monitor for seizures, maintain normal capnia and normoxia. Manage glucose and electrolytes carefully. Avoid hyperthermia after rewarming. We don't want to cause any arrhythmias or unnecessary hypotension. And then search for contributing factors like trauma, intoxication, underlying medical conditions, such as seizures, arrhythmias, or autism spectrum disorder. And then don't forget to support the family. This case is an adolescent with ventricular fibrillation. 15-year-old male suddenly collapsed during basketball practice. Coach finds him unresponsive without a pulse. CPR started immediately. AED is applied, showing V-fib. He receives 1 shock, followed by 2 minutes CPR. EMS arrives within 5 minutes, continues resuscitation after a 2nd shock, and epinephrine. ROSC is achieved. On arrival to ED, vital signs 120, heart rate, BP's 90/55, respirators are 24, assisted. SpO2 is 98 on 100% oxygen, temp is 36.5 Celsius. Physical exam, unconscious. Pupils are equal and reactive, no trauma noted. On the cardiac exam, you hear a gallop, but no murmur. Lungs are clear. EKG shows sinus tach with nonspecific STT segment changes. And the bedside echo shows a dilated left ventricle with poor systolic function with an EF of 25%. So do you guys do any sort of ultrasounding in the field? No, you don't have that capability. So I know that some EMS services are starting to incorporate that into their packages. Then in the emergency department, we're doing that as well. So what do we think are the immediate post-cardiac arrest management priorities? And then underlying diagnosis. Anybody have an idea for that? always.
As far as the rest of the almost normal findings, transport them to the ED and let them do their deal with labs and all that and figure out what's going on.
Yeah, for sure. So yeah, so you guys aren't going to do or cardiomyopathy, which I mean, I don't know that you guys are going to do much about that in the field, but I do think it's important for you guys to be thinking about these causes, like in the pre-hospital setting, so that you can give a good report to the ED staff when you get there, and then just for your training and overall education purposes as well. So ABCs, of course, targeted temperature management, as this patient was slightly hypothermic, assessed for seizures, neuroprotection, and then so the underlying cause in this case is likely going to be hypertrophic cardiomyopathy leading to BFib. The workup in the hospital is going to be echogram, cardiac MRI, genetic testing, and family screening. And then long-term considerations are going to be a pediatric cardiology consult, guideline-directed heart failure therapy if indicated, and then possibly an ICD. Potentially activity restriction from competitive sports for these folks. And then family counseling, as always. So teaching pearls from this case, most common cause of sudden cardiac arrest in adolescence is going to be structural or electrical heart disease, and these are often going to be undiagnosed. AED availability and early CPR is going to be key in survival for these folks. I think this is something that you guys do well as EMS professionals, is education for the general public. And then as medical professionals, always kind of be considering the cardiomyopathies, channelopathies, and myocarditis in these VFib patients without a known cardiac disease. All right, so key takeaways from this presentation: early recognition and response is key. High quality CPR saves lives. Always want to follow your guys' PALS algorithms, AHA algorithms, and then your local protocols. And then don't forget about post-resuscitation care, as this is kind of one of those things that can be overlooked and is critical in the overall outcome. Questions? Thoughts? Okay.
There's a fair amount of interactivity, all seeing the things that were already said in the room.
Sure. Yeah. All right. Well, thank you guys for your time. I really appreciate it, and hope that this was